Acting Commissioner Susan Ehrlich, CEO at ZSFG. I'm pleased to present the CEO report for April. And I sent you some information about the excellent questions you asked. When we get to the graphs, I think that are related to the volumes, we can talk about that. Okay, so starting with our social workers, we had a lovely celebration. Both Dan and I were there to celebrate the individuals who were listed here. I don't have a total count for social workers for you, but I will send that to you, and that will include both DPH and UCSF employees. The Wear Teal celebration is very adjacent to the social workers celebration, and there's a lot of examples of the programs that we have here where we provide mental health counseling. And one of the things that I wanted to reflect to you is that in the decade that I've been at ZSFG now this month, which is kind of remarkable, there's almost nothing that's changed more than this, which is that the extent to which we integrate behavioral health services with physical health services is almost complete. I can't really think of a service in the hospital where we don't, well, maybe clinical lab and environmental services, but all of the clinical services, by and large, there's some aspect of behavioral health counseling or service involved. Hence, it is very difficult to tease out how many mental health counselors we have, which is what you asked, because we can count the psychologists and the marriage and family therapists and the social workers, but there are many other behavioral health interactions that happen outside of those kind of specialty providers. Some of that is listed here. I mean, in primary care, we do behavioral health counseling all the time. Even apart from the behavioral health social workers and psychologists we have in the clinic. So we do a lot of it. It's very hard to define that specific thing, mental health counseling, as a discrete number. The other things I wanted to call out for you in the narrative report, I always like to call out the Values in Action winner. This month was Matthew Talmadge. He's the nursing director in the emergency department. I love, well, he's fantastic, as are all our leaders. And this, how he approaches work with genuine joy, purpose, and commitment to the team and patient well-being is really right on. And I hope someday you all get a chance to meet him. And then we rounded out our years of service celebration with the evening celebration we have, where we celebrated staff who had devoted 25 to 45 years of service with CSFG. And it's just remarkable to talk to folks who have worked at our place for that long, because, obviously they're very devoted. And just the joy with which they celebrate their tenure is really, really lovely to behold. And then I think I'll stop. Oh, I did want to say this one thing, the last item, the hospital tour. So our amazing Chief Nursing Officer, Jillian Otway, planned this amazing tour for students from Cappuccino High School and Latitude High School, some of which are interested and came in interested in being healthcare workers of some type. And I think they probably, after the tour she arranged, they probably all were interested in becoming healthcare workers of some type, because she really put everything into it, and we got a lot of positive feedback with that. So really nice way of demonstrating how we're working on the pipeline, even as young as high school students. Any questions about the narrative report before I go into the data?
So we're Latitude High School, I mean, Cappuccino.
Cappuccino is in San Mateo. I don't know where Latitude is it also in San Mateo? No. We'll look it up. AI will tell us.
How often do these tours take place?
We have tours all the time for all kinds of people. Not very often for high school students. We have internships over the summer, that involve high school students. In fact, there's one that we've had for many years. It's called Achieve. And so that is high school students. They generally come from Reardon High School and some of the parochial high schools and public high schools in San Francisco. So we see more of them in the summertime, but this was kind of a unique thing.
I think it's such a great idea, and
Yeah.
I, encourage you, if it makes sense, and to the extent that it does, to do that outreach to our, younger people in the city as much as possible, so that they, have a sense of what this is all about, and that this could be their future.
Yeah, we get a lot of interest in volunteering at the hospital in various ways, which is always really, it's wonderful to see that. It's a little harder if you're under the age of 16, but 16 and up, we definitely have opportunities for kids.
It's great.
Commissioners, yeah.
When are we having the blowout celebration for your 10?
Oh, every day is a celebration with me.
Non-responsible.
This
Yes,
institution
Counselor.
has evolved so much under your leadership.
Oh, you're
And I
very
think
kind.
Dr. Jasmine here probably the whole time we've been here, 8 out of the 10, and it's been quite remarkable. And we really appreciate you, as I know everyone in this room and everyone has stopped us. So we'll be waiting for our invitations.
Yeah, you could use to agendize that.
That's very kind of you.
It's been a decade.
Yeah.
Well, so much has happened.
So much has happened.
You've,
So much.
certainly, as President Green said, have been a very instrumental, if not the leading part of actually moving Terrell even more as a world-class facility.
That's very kind. It means a lot for you to say that. And I know it's not about me, it's about the team that we've assembled there. And I really appreciate your
Well,
efforts.
you assembled the team, so.
Okay, I can take some credit from that.
All right, let's go on to
CEO report.
data report.
Yes. Okay. So I will answer questions as they come along. So we've done 1 and 2, and we'll go 3 through 8. So we're doing better on equity. I won't spend time on that. Sepsis bundle, very exciting news. We have implemented the sepsis bundle. We implemented it on April 15th. And so a week in, we had, and this was as of Sunday, I think, we had used the bundle 35 times. And so, it's too early to tell what the impacts are, but definitely people are using it. We're noticing opportunities for improvement, which is, of course, what we would expect. So I'm really happy to say that after, literally a couple of years of planning, we finally have this in place. MOUD, this is a really interesting one. There's a lot of work and engagement on this. As you can see, we still have a graph that suggests that we don't have this yet, figured out. One thing that I know in the emergency department, even though the prescriptions, because remember the metric is about prescriptions on leaving the area, the ED, PES, and inpatient. One of the things that we realized is that the metric doesn't allow us to include long-acting injectables. So you can leave having had an injection, but that doesn't count for the data. So, and the other thing that has really happened quite a bit as a result of this is that we're getting more consults in the ED, especially from the addiction care team and from the substance use navigators from Bridge Clinic. So there's a lot of activity happening with people that is not necessarily reflecting the data we have here. So I think, this is great work. It's helping us understand what really matters and what will make a difference, and then we'll be able to capture that better in the metric. Okay, length of stay. So this is red. Lower is better. Our target is 5. Our rolling 12-month average is 6. but that's down from 6.66, that baseline. So we're definitely trending in the right direction. And there are a lot of countermeasures listed here on the chart. Part of it is lower level patients, but we're doing so much to get people out of the hospital. And you can see that reflected appropriately out of the hospital. And you can see that reflected on the lower level slide that we'll see later in the presentation. So I feel great about the work that Gabe and Jillian are leading to reduce our length of stay. This might be a good time to talk about the ICU. You're right, Dr. Chow, we don't have statistics here about the ICU. We have it later on, but it's hard to see what's really happening. But I hope you'll see from the graphs that I sent that we really have seen quite a reduction in the average daily census in the ICU. Now, we don't, I say this with all humility, we don't really fully understand why that's happening, but what we do know is that the length of stay in the ICU has gone down by about a day. And so that is what we think is mainly driving the reduced census in the ICU. That is also related to, in part, to the drop in revenues that we're seeing this year. It's still, we're still in discovery with that, but so the point is that not only are we seeing a reduced length of stay in the med-surg unit, which is what is reflected in this graph, but also in the ICU. In the percent of acute patient days in our inpatient unit, we are also, this is also in the red, and here higher is better. Our target is 30%. Rolling 12-month average is 25.3, up from 22%. So we're definitely heading in the right direction here. And this is about better turnover, obviously, in the inpatient units, but it's also making sure that we're fully documenting when patients are acute. And so there's work being done on that, which will also help with our revenues. Going on to the next slide, the Merck inpatient bed occupancy. So this is also trending way up. I mean, here, higher is better, and you can see that our target is 95%. Our rolling 12-month is at 85%, and that's up. That's way up from 72%. So I really credit Joan and Angelica, who are doing a great job, which we talked about before, about how getting the Merck as full as possible, which is a very important part of allowing us to move patients out of our acute psychiatric units. Boarding as well is down, going in the right direction. We're still red here. The rolling 12-month average has not hit the target, which is 15. But again, you can see the trend going way down from the previous baseline of 31 to 23. And that is possible because we are moving patients out of the hospital faster. And then the total reportable incident rate. So here we're seeing the rate going up, which obviously is not what we would hope for, except, and here lower is better. We're in the red. Our target is almost 12.4, and we are rolling 12-month is 17.7, and that's actually up from the previous fiscal year baseline. But here, what we're happy about is that people are more often reporting. And you can see in the next graph that that shows the type of events they're reporting. And you can see it's really the lower acuity events that they are reporting. So that's really the thing that has made the rate go up, which is important to see. Dr. Green, you asked about the threat management team, which has been truly remarkable. Almost from the very beginning in December, this team was assembled, which is made up of 4 people. And those 4 people are very involved in answering the threat management line. I think their goal is to answer that line within 30 minutes, and they're doing that almost all of the time. And then they're very detailed, assessing the level of threat, is it low, medium, high, and then working with the teams on the ground to make sure that they have a very solid plan, which is really complicated to do because it's not just about a patient going to one place. At our campus, very often people are going to a lot of different places. So the kinds of things the plans are having to address when there's a high threat, especially if you're, how you discharge a patient from a clinic, you know, and what are the circumstances of doing that? And then if the patient is discharged from one clinic, then what happens when they present somewhere else on campus? So these are the very complicated things we've been dealing with, and those are reviewed not just in the local, you know, the ground level safety committees, but also at OSOP, which happens once a week. It will happen tomorrow morning at 7 a.m., and the PSOC, which is the policy committee. So all of those moderate and high threat cases are also reviewed at OSOP. I hope that gives you a little bit more information about threat management. Okay, so the financial metrics, accounts receivable days, this is in the green. So our target is 63. Lower is better here. Rolling 12 months at 58.7, and that's way down from 64.2. So this is active accounts receivable over the average daily revenue, and you can see we were going up and up, and this is all, you know, where we're seeing problems is all related to these issues that we're having with the health plan. And I know you asked me to describe the relationship between the medical center and the health plan. And it's a big, you know, there's a lot going on there, and it's a complicated relationship. I will say that it is better than the average relationship between a healthcare provider and an insurance company. And that doesn't mean that there aren't issues, but we work together very closely on a lot of different things, including this. So our finance teams are working together to try to resolve this. It's taking too long, and we've escalated, but there you have it. That's the simple version. The next one is the gross collection ratio, which is the ratio of net payments collected over gross charges for accounts. Here we're red, the target is 13, the rolling 12-month average is 12.27. And we're actually lower than the baseline, again, because of the issues we've had with the health plan. This ratio, it was, I looked up, you know, what's the industry standard for this ratio, and it's 30 to 40%. And you can see what ours are, and that just reflects the nature of our payer mix, right? We just don't have good payers by and large, Medi-Cal and Medicare. And then last but not least, the denied rate. This is payments resulting in denials over the total number of payments. Here we're green, lower is better. You can see we're trending up a bit, but we're doing okay right now. I'll pause there on the strategic metrics before I go to the next ones. What questions do you have?
Commissioner? No, we'll proceed.
Okay. Okay, so this gets to the last question I think that I didn't answer, which is the ED average daily volume. And you can see, you know, it's not just this month that the ED volume is high. It's been creeping up over time. So we are getting busier and busier, and because we have less boarding, we're better able to handle the volume, which is great. And also because we put so much work in triage, you know, we're seeing more patients there as well. So people are not leaving without being seen. So this is just a trend upward, which, you know, I can't explain all the reasons why, but it's not just this 1 month. Percent of time on ED diversion, this is such a happy story. April, we're at 13.3. There were a couple months in May and June of last year where we were at similar percentages, but this is a remarkable improvement from the highest one ever was in May. I look back, May of 2022, we were at 76.2% for the month on average. So I just give a lot of credit to the ED team for keeping us down so low. And again, this is also related to the fact that we don't have boarding. We've really been able to improve our throughput in the hospital. The psychiatric ED average daily volume, I'm not sure why it went down in March. I can get more information on that, but generally it's been pretty stable. So I will get back to you on that. Average length of stay, we talked about before. It's going up a bit in psychiatry because we're having issues with placement, which do happen from time to time. We always have issues with placement. They just are up and down at different points in time. And then the other This next graph shows you the difference between length of stay based on observation status, I think, which is helpful. And then you can see the reduction in lower level care days. We're down to 1305, which is still above our target, but it's a really nice trend down. And then I think I'll stop there and see what further questions you have.
So I'm just looking at if, in fact, the ED days are up, but the number of admissions, well,
The
the number of
admissions,
inpatients is down, and the ICU particularly is down. Is there a change in the severity mix of the patients coming in?
well, so this is what we were talking about with respect to the ICU. So the visits in the ED are going up. There's no reduction in patients being admitted. In fact, that's, either the same or going up. It's the length of stay that's going down. And that's what explains that. Now, especially in the ICU, because the drop is more dramatic, we're wondering, well, what's going on, right? Some of it is that patients aren't boarding in there. Are the patients less acute? Well, the number of respirator days hasn't gone down. So that suggests that they're not. So, we're trying to dig into this more and more, but I think, what we can reliably say is the length of stay has gone down. We're not boarding as much. What the nuances are of that, we still have yet to discover.
Commissioners, further questions? There are no further questions.
Okay, thank you so much.
We could go back to HR report.
Afternoon, Commissioners. So for our HR vacancy report, as you can see from the report, our March vacancy rate is 5.84%, and apologies for the clerical error there. It said February, it's supposed to read March 2026. That's 0.73% with attrition savings compared to 5.51 last month. No new hires in March. We've had 12 separations, and 5 of those were retirements. The RN vacancy rate is 2.94% or negative 1.92% with attrition savings. As far as our HR updates, you may have heard this from the Laguna Honda JCC. We are working on a DPH resource, HR resource center SharePoint page update, and it has a goal of improving access to HR services across the department. So it'll also help streamline the navigation of different forms and pages, and it will support a self-service model. So we'll have service level agreements helping to make sure that requests are responded to on a timely basis. The go live date is anticipated for July, so we hope to have some data from that page and the requests that are coming in, hopefully the quarter after it goes live. As you can see from our summary of hiring for RNs, the highest vacancy rate right now is with MedSurg at 6.60 FTE, followed by Periop and then emergency and ICU with some selections pending. We hope to see some additional vacancies being filled in the coming months as positions get prioritized and reapproved. Are there any questions that I can help answer?
Questions? I guess my one question, then maybe the question is related to the hiring freeze and whatnot. Amongst all the listing of those greater than 10% or more in terms of job categories, I noted that actually there's only about 6 or 7 of those categories in which you're doing interviews, and that the remainder, large number, says that we're pending approval of the requisition or even waiting for the submission of the requisition. So And the larger number seem to be requests from the hiring manager. So even if you have a freeze on, hiring managers could still ask you to hire, right? So is there a reason that so many of these really are still vacancies, but the hiring manager hasn't felt that they need to be filled?
So that's largely a process that's being handled by our DPH program leadership in coordination with finance to really prioritize the positions and determine which ones are most urgent to fill based on, directives from the mayor and DPH guidance to make sure that they're filling patient forward positions. And so really it's a matter of that prioritization process taking place. So some positions may have already been under a selection process, in which case if they weren't prioritized, that process paused until the prioritization took place. And then as positions become prioritized and reapproved, because some positions were turned back to proposed and were essentially unapproved to move forward, until they get reapproved, those positions that we're receiving as designated to move forward are moving forward. So I don't know if that helps answer the question, but we had some positions that were in different stages, and as they were undergoing this process of prioritization, some of those were approved to move forward and some were not yet approved. And so you may see that, in where there's higher vacancy rates, those positions may still not be approved to move forward.
Okay. All right, well, and probably some of them they have been eliminated too, if they were vacancies.
Right, and as we receive communications, we haven't received that information yet. I'm sure between finance and executive leadership, they may have more information, but as information comes known to us, then we move on those positions as quickly as possible.
Okay, I guess I guess it won't be until July, right? When the new numbers for different categories are really.
Right, when it becomes official.
Right, and that would then change I guess the landscape there.
Yes, that will definitely show in our numbers when we know for sure which ones are approved to move forward in the next fiscal year.
Okay, any other questions? Anybody? Yeah.
What are the nursing messages fit in all of this?
So again, those are actually positions that, let me see, do we have them specifically on here? 2330s. Yes, so they're on the vacancy report. And right now it looks like there's budgeted 15.28 FTE with filled 11.40 FTE and vacant of 3.88 FTE. So there's still some vacancies there. And as nursing leadership identifies those as prioritized, those are moving forward. Again, HR doesn't make that determination. We wait for, nursing leadership in conjunction with finance to make, to let us know which ones of those are moving forward. So there's still about 3.9 that are vacant currently.
So when it says pending an announcement examination administration 60 to 90 days, is there a likelihood those vacancies would be filled by then?
That's a great question. I will need to check back with our other HR team who does the examination announcements to determine if the list could be done quickly. They may have already been in the process of, getting everything ready for that next list adoption. But I'd have to check with them and get back to you on that.
Thank you.
Okay, well, thank you for your report.
Welcome.
I'll look forward to the next one.
Right, we can move on to item 6, a ZSFG strategic planning and deployment. Pull up the presentation. Please just tell me to go to the next slide when we're ready.
Good afternoon, Commissioners. Hamilton's Area Chief of Performance Excellence. Afternoon, my name is Rala Rai. I'm our strategic planning manager.
Could you both speak up a little louder?
Absolutely.
Okay.
Good afternoon.
Good.
Thanks for the opportunity to be here today. We're really excited to go through our strategic planning and deployment process, which we term HOSHN as we approach Lean. We do this annually for you all. So we can go to the next slide. I briefly wanted to highlight that the sort of mission and the vision of the KPO is to be stewards of our true north and to help develop people. We do that through many different avenues. One of the main aspects of our work is supporting our organization, ZSFG, and the teams there through our strategic process, which we're going to go through in some detail today. We're going to give you an overview of that process, talk about our updated key performance indicators, and the actionable next steps coming out of last year's HOSHN. Next slide, please. There's lots of terminology in Lean, and I just want to emphasize it's here for you if you want to reference, but we're not going to go through it in detail other than to say this is our HOSHN process or our strategic process. Next slide. So my main role today here in presenting to you is just to highlight the many successes that have come out of this process. It's a very rigorous process that has resulted in many dramatic improvements. And those improvements are due both to the process that we undertake, but also to the people, most importantly. So I really wanted to shout out the executive sponsors who lead each of our strategic efforts, the KPO team, including Radha, who helped steward this effort, and then all of the operational teams that we work with that align towards these goals, and highlight that, you know, we're for many of the metrics here are some of the example ones that have happened since the last year that we presented to you. And these are all sort of the best versions of where we're at today, compared in the last sort of decade that I've been here. And so if you, Susan, Dr. Ehrlich mentioned a couple of these, but our diversion is down from an average of high 60s to low 20s this year compared to 2022. We're at the best effort around our financial stewardship. We still have ways to go, but we're at our lowest denials rate that we've ever had. We're at our lowest AR days that we've ever had. After 3 years of planning and efforts and alignment with our informatics teams, we just went live with our sepsis pathway. We're using Project Phoenix, which is our data dashboards, as you see them in JCC, but we're using them throughout the organization right now. And those are all elements that have been embedded into our HOSHN process. I feel really proud of the team and the efforts and the outcomes that we've had, and I hope that we can continue those efforts moving forward. Radha's going to go into some of the details of the process, and then we'll both be here to respond to questions.
Thanks, Emma. Yes, this slide. So this is our 7-step strategic planning and deployment process laid out, beginning with our true north or guiding principles. And you'll see that it's a very methodical process that ensures the consistency and focus. And as Hemel said, it's an iterative process too. We do get better at this each year. And I'll go through each of some of the phases in more detail in the next slides. Next slide, please. So as you'll see at a high level, this process follows our scan, plan, do, study, and adjust process, which kind of highlights our commitment to continuous improvement. And you'll see that it's a year-long process, cycles throughout the year, and it begins with a rigorous scan phase, which is where we're collecting qualitative, quantitative data to help understand what the current landscape is. And we look at things that are happening at the national level and bring it down all the way to the community. What are their needs? We also engage with a large group of people, our executive teams, and all the way down to our frontline staff, and we include our patients. And we do this in various platforms through our meetings. We've got one-on-one interviews, and we also have a survey out that last year to gather more information and feedback. And what we do with all of this information, and you'll see some examples of how we've gathered information from our teams. We take everything that they've given us. Sometimes it's through these stickies, through the survey responses, and we create a very we synthesize all this information into a structured analysis here, known as the A3 on the right. What that is basically telling us is that's highlighting what are our strengths? Where did we do well last year? What are our weaknesses? Where do we need to improve? And what are the threats and opportunities that we should be focusing on for this upcoming year? So example, last year, HR1, biggest threat. How are we going to maintain services to provide to our patients, recognizing we're getting less funding and also the potential of increase in demand for this year? So we took all of that information into consideration. And yes, next slide, please. And this is just showing you as well is that when some of the information that we're looking at, we're making sure we are aligning with the department and the network priorities to make sure that we're putting forth supports these overall priorities as well. Next slide, please. So now we're at the planning phase. So that means we're taking a lot of the information, all the information we got from the scan, and we're seeing how can it apply to our upcoming strategies? How do we use that information? This is where our strategy owners look at the information and they set forth strategic plans. They understand what metrics they should be moving towards, KPIs that are reported out, and they help identify the teams that are going to help execute this plan moving forward. And last year, we've focused on refining the current strategies that we had and strengthening our execution of those strategies. And one way we have worked on strengthening execution was we wanted to align our resources together. So we've got a fellowship program through our Kaizen Promotion Office where we take leaders from across the hospital and they apply for this program and they have to showcase some projects to us that align with our strategies to recognize or align the work that we're doing forward and help move these strategies forward. Next slide, please. So here are our four core strategies that we focused on, and as Hemel mentioned, they have executive owners. There are 2 executive owners for each strategy, and that's to make sure we have accountability, responsibility. And you'll see they're laid out here. One is flow, making sure we are providing the right care in the right place at the right time. We have workplace safety, ensuring our hospital is safe for our patients and staff. We've got revenue cycle to make sure we're good financial stewards. And we've got our patient safety strategy, ensuring that we are reducing or minimizing harm for our patients. Next slide, please. And all of these strategies you'll see align with our true north goals of equity, safety, quality, developing our people, and financial stewardship. And what this slide is showing is how we actually measure progress of all of these strategies. They are 12 KPIs, which you see every month with our CEO note, just putting in a table form here all together. This last year, we refined our KPIs, and we also added new ones. So the new ones are highlighted in yellow here. Like we added mental health rehab center % occupancy. And we removed some metrics from last year. If you remember, there was boarding and PES that continued to meet and exceed expectations. And so that was moved now to a watch metrics. We actually improved by 32% there. So this is how we make sure that we're focusing on the right things with our KPIs. Next slide, please. We're measuring our success. So we've got our strategic plans. We've got the teams identified to help execute. Now, this is one of the most important phases of our strategy deployment process. This is the doing phase. So how do we make sure we are moving strategies forward? Set up the plans and everything. This is where we try to embed our strategies into daily operations. So you'll see we've got a strategy in the bottom left picture. It talks about our strategy. First, our true north, that is our guiding principle. Then we've got our strategic A3 that sort of sets directions. That cascades down to operational teams. There's an example here of what we did with our flow strategy. Flow has 7 different departments working to help improve and move forward their KPIs. And they're listed here. Now, each of these teams meet regularly. They look at their data, they review it. If they're off target, they problem solve in their huddles, and they continue to make meaningful progress forward. Another thing we've done here to help with barriers is we've aligned or organized exec leadership rounds, where leaders now attend these huddles and help teams problem solve or overcome challenges to make sure we're continuing to move in the right direction. Next slide, please. So in addition to really refining our strategies from last year, other things came out of what we wanted to focus on this year. Those are, one, bringing back patient voice to the work that we do. So we're in the process of drafting a patient experience strategy. That's in the plan phase so far. We're excited about that. Second is assessing improvement capabilities. So what that means is we are trying to strengthen our daily management system here, which is really how we're turning our strategy into daily actions and measurable results. This is done by aligning the teams, making sure we're all aligned on the strategic priorities, having teams set up their own KPIs or metrics to work on, and having huddles around that, recognizing, reviewing the data, problem solving if we're not there yet, and continuing to make progress and get better with these teams. And of course, celebrating the wins when they had them in these huddles. And the third thing we're looking forward to is, again, a second round of, or an upcoming new round of fellowship to join the current round of fellows to help support, again, more strategies moving forward or in different ways to continue to carry our strategic priorities forward. So in summary, that's our approach, recognizing that strategy is not static, it's constantly evolving. We're looking at data to make our changes, and we're aligning teams across to build up our capability and help improve outcomes.
With one concluding remark, wanted to mention that for me, performance improvement and lean is really a marriage between the different tools we use, which you have some of the tools visualized here, huddles, Ocean, standard work. You hear about these in our presentation. Those have to be married with behaviors. And so again, like Dr. Ehrlich and all of the other team members that you see here really exhibit this collaboration between use of performance improvement tools with principle-based behaviors, going to the workplace, seeing where the work's done, understanding from experts, from your frontline teams, from your patients, asking questions. So there may be stuff that we don't know the answer to, but I think trying to approach it with curiosity and enable staff to take action on them, that's sort of what this is all about. And we feel like this has helped us get some of the outcomes that we want for our patients and for our colleagues. So happy to take any questions with that presentation.
Appreciate what yes, great.
Well, first of all, thank you. And I really applaud this work because I think so often in the healthcare systems, things come from the top and filter down. And so often you don't see leadership on boards or really talking to frontline staff. I think it's one of the biggest complaints you'll hear in so many institutions across the country. And it seems like it's your secret sauce that, hearing from people doing the work, it seems to make sense, and yet it's very uncommon. So I really applaud you for doing that. I guess I have one thing that I wondered, how are you using AI in all this, or will you? I mean, it's kind of a really interesting question as we're kind of looking at these tools, and so many analyses can be produced in a heartbeat that 8 months ago we could have done this, but it has its drawbacks. And what I love about what you do is it's so personal with people. Everything about this is people interacting, not, it always worries me that you inflection on text you read, right? And that can lead to so many miscommunications. And yet really the underpinning of the work you do is the, eye-to-eye contact with the patients as well as with each other. So I'm just wondering how you're thinking about that.
Great question. Thank you so much for that. And I'll mention, as part of the KPO team, we have a data science team that is very skilled in advanced analytics, including AI and machine learning. And over the past, I would say, 12 to 18 months, we've really had success with embedding them as part of our strategic efforts. And so, for example, today, if you came to the flow strategy meeting that Dr. Ortiz and Jillian co-led, we actually showcased a lot of the analysis that we've done over the past 9 months that combines typical lean performance improvement analysis, like we're using post-it notes and process mapping and engaging frontline staff, alongside a traditional regression analysis, looking at factors that impact length of stay, alongside using large language models to look at all of Epic's data since our go live, find our highest, most common DRG diagnosis categories, and then pull from LLMs what are the main concepts that contribute to prolonged length of stay. And so we've used those 3 different buckets, lean, typical analysis, regression analysis, and AI, to have a complementary and very comprehensive assessment of our length of stay work. And we're using it to identify, like, what are the 3 to 5 biggest themes that we need to work on. And so we have that information now. We're also able to simulate if we were to work on, for example, MRI utilization. We think that we could shave off 1 day or 3 days or whatever if we were to do this quality improvement project. And so that is one example with how it's been embedded in our flow strategy. With the workplace safety efforts coming out of what we were doing already that Sabrina and Angelica are leading, the Prospect Lab and KPO are also supporting the data analysis. And so the one example is we're looking at all of the behavioral flags in Epic and sort of describing who gets those flags, who puts the flags in, where are they located, what do they say? And you can't just do that with structured data in Epic. Structured data is like a specific field, like gender or age. That makes up 1% of data in electronic health records. Unstructured data, all the notes, is 99% of data. And so we were able to use all of the unstructured data and evaluate, like, what are the qualitative comments around those behavioral health flags. And then we're in the middle of an analysis looking at those flags and then safe reports. And again, trying to identify what are high-risk features, what are low-risk features. And so that's still a work in progress, but I wanted to give you a couple examples of how we're leveraging AI in our strategic work. And I only see that growing over time. The technology is advancing so quickly that the work that our own team did, I would say 4 years ago, is excellent, has had great outcomes, and is obsolete at the same time. And so we keep on sort of innovating. We're really lucky to have local experts that are, part of the ZSFG and part of the KPO. And I think it's a privilege for me to learn from all of them and my whole team here.
Well, that's wonderful. Do you ever, like, if you're going to do an A3, do you ever pose the problem to AI and see if they spit out? I mean, after a while, they get to know a lot about it.
Yes, good question. I have not personally done that. I have heard of people doing it, and we work really closely with national partners who are sort of experts in lean and performance improvement. And actually, they're pretty interested in this and using technology for coaching, for education, and for mentoring. And so that's something that we've started conversations with them. And Rob, for Stephen, anybody thinking out for their own A3 thinking? Okay.
Open evidence, yes.
Open evidence, yeah. I think there's opportunity there. And I think in general, AI is a tool and it can be helpful. And then it can also, I think there's the evidence for it, I think, is still developing. And so one thing I've learned from my peers is we want the same level of rigor, academic rigor, to assess, how effective is it. I would love to be able to go in and for it to document for me. I think I need a peripheral brain. I would love for the AI to say, Emil, make sure you're thinking of this. But I also want to see the evidence is there to do it. And I think we're still developing that right now.
Well, thank you. I love the best thing is seeing Post-its and all the pictures, because Post-its are going to be gone with AI pretty soon. It's great they're still being used, because there's something about putting it to paper, making it know it goes through here, instead of from here to here. So I really appreciate it. I'm interested to hear how you plan to safely deploy this tool that, we'll be having a different discussion maybe 8 months from now.
I think it's very complimentary. Like I think so Radha and Chris, they're so amazing at engaging the humans in the process. And that's a really key part of the process because like it gets at culture, it gets at things that you may not see in Epic. And coupling that with the technology, I think is could be very effective. I think it's very effective. And so I see them as sort of complementary approaches that we can create synergy and allow us to move forward in the most effective way.
Thank you.
Thank you. I've been wondering as I watched your presentation and also had scanned it earlier, and then reading what the family practice people do as a department and what all of our amazing departments do. How is it and where have you been able to actually capture the attention of all these people who are really working, right there, taking care of the immediate problems to actually go through this entire exercise to get through your cycle as they're, following their students and same time doing their surgery or, running their departments or working credentials files and all. I mean, there's just so much work. So how do you get them to have accepted that this is going to be part of it? And what challenges do you think you have for the coming year on this?
Well, I think I can start kind of sure. I think that we engage with a lot of different teams and we commandeer existing meetings to make sure that we can hear from a variety of folks as well. So, for example, there were some pictures here that we showed for our expanded exec team. We had directors, executives come to that meeting from all divisions and we'd ask them questions and get their feedback. So we had already out of the bat, lots of different disparate ideas to put together. And we've been also communicating this whole process with them over the past few years. They're expecting it, it's ingrained, I'm hoping. And again, we are continuing to see there's areas for improvement in terms of communicating strategy, what the process is. But we've been putting on road shows for folks as well to understand the process, to really see value of the input that they gave and how it's being used. And recognizing too that this is helpful for our teams to improve their processes. We're trying to make things more efficient and streamlined for them as well, so that they could focus on the things that are most important, patient care.
Yeah, no, I think that's great. A couple like additional considerations. I think this work can't be on top of your work. It has to be embedded in it, and it needs to have value for the people. They need to find value from it, and so our job is to, help support them, and then also hopefully that they find value, that this makes their work easier. It's not performance improvement or A3 thinking. It's not on top of your normal job. I think that's our aspirational, hope, and I think that we've made a lot of progress in that. I think the second part is alignment. And so something that we've worked really hard on over the last couple of years is ensuring that we have people's fingerprints on this. So what you're seeing today is not just in the executive team's head. It's something that they have gone back and forth with their teams on. It's something that frontline staff have had their fingerprints on, and there's many examples of this from across the organization. And even beyond that, it's still sort of like deciding how to prioritize. You can't do everything. And so you'll see that we have 4 strategies. There's 12 KPIs. One thing we're doing this year, that we've done over the recent years, is something like length of stay. That is something that, hopefully every single individual working at ZSFG can see their own work as impacting that metric. And so again, that's like a aspirational hope for us, is that every staff member sees their own work represented in our strategic efforts. And then we also create opportunities to align. And so this year, I think for the next part of your question, Dr. Troy, was what can we do over this next year? So one area that I think we are need to do better on and could continue to do better on are how are we leveraging or aligning the Performance Improvement and Patient Safety Committee, so PIPs, with our strategic efforts. And so we're specifically going to be encouraging and then looking at how many units reporting at PIPs are aligned to our 12 KPIs or CMS STAR or our 5 True North outcomes. So really measuring that and encouraging that alignment so we have some acceleration in those outcomes. I think another example that's coming up, you probably are aware that the San Francisco General Hospital Foundation has philanthropic opportunities that our staff respond to. They're called the Equity and Innovations Grants, EIG grants. They used to be called the Hearts Grants. Again, this year we're really emphasizing we're going to give preference to applicants who aligned with strategy. For our KPO fellowship, we have preference and we're hoping that all the fellows have a personal development plan and they also have a project that is aligned with strategy. So all of these efforts support alignment, as does our Project Phoenix, which gets everyone to look at the same data. So there's a single source of truth. We're all looking at the same length of stay data together and then working on that and measuring impact. So those are how we're approaching it. And I think also that we have more opportunity there.
Well, very good. If I were chief of service, what is it that I would then benefit from in terms of what your group is going to do for my department?
Okay. Thank you for asking that question. I'm gonna share a little bit of my pride, but I'm gonna make it not just about emergency medicine. I will say that Dr. Mercer, who's chief of staff, myself on the executive team, Dr. Peabody, who's the associate CMO, and many other people in our department have been KPO fellows, have learned about lean and performance improvement through Dr. Ehrlich and other leaders at the organization through this model, took the A3 thinking class, and have embedded this, both the tools and the behaviors in our approach to work. And so for my chief, Dr. Caldwell, I think he sees this as a way to develop people. You know, it's helped several people in his own department develop, have additional opportunities, make an impact. And so I think that's one obvious thing to me. I think we're looking to develop the next crop of leaders in our organization, and to really our vision is how do we develop 6,000 problem solvers at the General who can take an item that they see that's a pain point for their patients that they're serving or for them in their work, and enable them to use data-driven, the scientific method to improve stuff for our patients and for our colleagues. So that's one piece. I think the chief want their teams to be developed. If we allow for our people to work on the most important things, it also brings them visibility. They get additional mentoring, skill sets. They get exposed to, so for me, when I was a KPO fellow, I got to work on stuff that some stuff that I had knowledge in, but a lot of stuff that I didn't, that I was not the expert in, and I learned that process and then developed through the process. Yeah, I think it's just a way to make an impact, and people who are at the General and people who are in BPH, like they're here for the mission. So it allows them to align on our mission in service to our patients.
Well, I think this is still another aspect of how exciting it is that we're able to help support you at General. We don't see that or the opportunity to do that in many of our own work previously. The hospital or staff were just fortunate to keep above water and to be able to have that opportunity and really to be able to look at a different way of also taking your knowledge and moving it forward for the improvement of patient care, I think is really exciting. And the work you're doing is very much commendable.
Thanks so much. Thank you so much. I think as like a last point from my perspective, I think getting a chance to take care of patients, then getting a chance to work on system improvement work through this type of environment and then getting to evaluate what we do and disseminate it. I think a lot of this work we're disseminating in academic, publication, peer-reviewed publications. And I think that, to get to your question around what chiefs, might care about, I think that I'm representative of the person that works at the general in that way. Radha's been involved in a number of our dissemination efforts. And so again, I see all my colleagues sort of doing work like that. It's something that makes the general just a really special place to be.
Well, thank you very much. I look forward to watching your work as Dr. Early continues to present the status of all the KPIs. And now we'll know the background behind it. So we really appreciate your work.
Thank you so
Thank
much.
you very much.
All right, we can move on to item 7, staff report. Dr. Mercer, can you clarify verbally about the non-staff, the status of what we're doing today with
Yes.
with the president meeting?
Yes, thank you so much. Good afternoon, commissioners and Mr. Morowitz. I'm Mary Mercer. I'm the chief of the medical staff. I'm here to present our medical staff report, and I believe the item for action is to approve our report and the rules and regulations, as well as the privileges that are put forth and have been presented to the medical executive committee. So we'll go through those. Is that correct?
Yes.
Okay, so we will kick it off with the Family and Community Medicine Service Report. Again, the MEC had the pleasure of hearing from one of our service chiefs, Dr. Viela, who leads our Family and Community Medicine Service, which really is a great example of multidisciplinary work across a number of the settings, both acute care, long-term care, and primary care in ZSFG that ZSFG provides. So their scope of service is quite broad, and although family and community medicine is a very broad specialty, it's also, as you can see, they have developed many areas of deep expertise. So there's a very active inpatient service that is often, running above their target census. They run multiple clinics in the outpatient setting. So the Family and Community Health Center is very active, as well as the Bridge Clinic within the Family Health Center, which provides transitional services for patients with substance use disorder. It is having a profound impact on our patient population. The gender clinic within the Family Health Center also is an area of deep expertise. And then 2 longer-term care units. So the 4A skilled nursing facility and our mental health rehabilitation center. So very broad and active service. I think the report that you received and the supplement of the PowerPoints just shows a lot of both experienced and well-seasoned leaders and new and emerging leaders that are leading in education, clinical operations across our campuses. And the team, again, like our other services, is very involved in patient safety and improvement efforts. In all of the settings that I mentioned. And actually, I forgot to mention another area where there's great work is with our interdisciplinary teams with family planning and labor and delivery, where there's an embedded family medicine practitioners within those teams. So bringing expertise back to the family medicine team as well. And I think they've done a number of fantastic improvement efforts to really center patients and to advance health equity. They also have a great interdisciplinary team. I think there's a question around how a team that is represented both by medical staff and affiliated professionals who are both university and DPH employees, how they work well together and have collaborative care models. And I think like our other services, Family and Community Health does an excellent job of having very streamlined collaborative practice, and maintaining high quality of care and consistent standards across all of the groups with different licenses and different scopes of practice. And that is the Family Community Medicine report. We go into their rules and regulations. There are just some minor changes in terms of their updated org charts and then their updated privileges, but no significant substantive changes within their rules and regulations for family and community medicine. Happy to take questions about that.
Commissioners, questions on the chief of staff report here.
Yes.
Yeah, I'm just curious about that. The open privileges are quite extensive, even back and forth, and it wasn't clear to me whether they would only assisted sections or it could be primary surgeon. There's something where it talks about C-section, he didn't necessarily say, but I'm just wondering about the supervision of that and, how that all falls in terms of a lot of things sort of default to the obstetrics leadership, but it wasn't clear to me exactly where family practice leadership fits into all of that.
Okay, thank you. That's a great question. So I'll have to get back to you in terms of the exact proctoring and supervision. I can speak to the proctoring of the privileges. So for participating in C-section, I do not believe that there are family and community medicine faculty that are performing them independently, and it is embedded. There's always an OB/GYN faculty that is on duty in L&D, but there's consistent common presence of family and community medicine physicians that participate in and kind of provide the full spectrum of care to their patients. But the L&D suite in particular is a very collaborative environment. So it's similar with the midwifery service, collaborating with OB/GYN faculty. If a patient needs a C-section, then the OB/GYN faculty are involved. In terms of proctoring for the OB suite of privileges, anyone with the privileges can proctor. And so there's shared proctoring responsibilities for family medicine faculty that have the labor and delivery privileges, or the obstetric privileges by OB/GYN as well as by family medicine.
And it sounded like in one place that I had to look back, there were a lot of cases, like 20, I can't remember if you had to do 25 backups, 25 sections, but the volume of the county is, how is the volume adequate for all your OB/GYN residents to have adequate proctoring and experience and family practice? How's that working out given the volume of deliveries per year?
That is an excellent question. I know that we had a dip in our volume, and now our volume of deliveries has been stabilizing and even increasing. But I can ask our chief of service for OB/GYN around how the volume counts. And also, I think for a number of these cases, multiple people participate. But so it might be that if people are participating in the same delivery, they're all being proctored for that. But
That'll be interesting because you want to finish your training and have your experience to be qualified for hospital privileges, or at least for short-term proctoring in your attending position. And I wondered not just how the county, but how hospitals in general, the volume is more dispersed or managing to feel comfortable about the experience of their trainees.
I think it is a perennial question. And I think there is a question about proctoring. And if there isn't sufficient volume in a certain period of time because of caseload, then we actually drop that privilege for that provider and they need to reapply and seek out additional opportunities.
Thank you.
I was looking at your org chart.
Yes. Yes.
And it just got a whole bunch of straight and dotted lines all over the place. So
Yes.
I'm not sure how this actually operates.
Right. That's very helpful.
color to the question that you sent. Yes, we are in a very, what the common term is matrix organization. And so there are many different modes of supervision and leadership. And ultimately within the family and community medicine side for the clinical department of physicians and staffs, that anyone who's an employee of UCSF reports to the chief of service. But then similarly, we have clinical operational leadership. So the medical directors, the acute care, the associate chief medical officer of ambulatory care, or the associate chief medical officer of medical surgical care. So there are many different reporting relationships that have different outcomes that are being measured. And I think it's a testament to our 150 plus year partnership that we do really try to align priorities and align have shared definitions of quality and safety as they're presented today, so that we can hold individuals accountable within those reporting relationships.
So it works at the grassroots level.
At the grassroots level, the nursing director, nurse manager, and the medical director working in partnership to supervise their direct reports in service of the shared mission. Yes.
And how, I couldn't actually tell, but how large is the department when you count the faculty and the residents, and they seem to be is this the largest department?
No, it's not. It's not the largest department. No, it's a relatively small department. The Department of Internal Medicine is the largest, but it is, I mean, out of our in terms of the primary care services, it would be the second largest after internal medicine. But I believe the RFPC clinic is the largest internal primary care.
She is bigger than ours.
Yes.
Okay. Well, it seems to operate very well. So,
Yes.
and if President Green is satisfied with the OB privileges.
Yes, I will follow up with Dr. Gavila and Dr. Jackson.
We appreciate your report, and we can go on to the business that you are asking us to.
Great, thank you. The next was the CPC NP 103 privileges list. So this is similar or related to family and community medicine, and that these are the privileges for the NPs that work in any of the community primary care clinics, including family and community medicine, family health center. But of note, this is our first presentation of nurse practitioner privileges. So up until now, because of SB 890, nurse practitioners within the state of California had to operate under standardized procedures. And now with the Senate bill, there are two different statuses of privileges that NPs may apply for. So they can have 103 privileges where they're practicing under the supervision of a physician, but with equivalent privileges to other physicians or medical staff, physicians, dentists, et cetera. And then a 104, NP 104 privileges is in the state of California, allows NPs to practice independently. So in our organization, our Committee for Interdisciplinary Practice, along with our Credentials Committee, have been working with different groups of nurse practitioners to identify what our NP 103 privileges should be, and to transition everyone who is eligible to a privileged status rather than a standardized procedure status wherever possible. So this is our first set of those privileges. And they really echo very closely the privileges that medical staff members have in that area. And like SPs and like privileges, they're subject to the same quality improvement and oversight expectations.
any comments on this, CPC, privilege? So,
Yeah, so this just shows you the adult privileges and the pediatric privileges for CPC.
Sure. Thank you. What are we doing, vote on?
So the request is to approve our medical staff report, including the family and community medicine rules and regulations, and then the credentials committee privilege list for CPC NP 103.
Okay, is there a motion to that?
So moved. Second.
Second.
All those in favor, please say aye.
Okay, our next item on the agenda is a review of a long time coming update, initial draft of our recommendations for amendments to our medical staff bylaws. And in your packet is included a summary document that summarizes by article at a high level what the changes are within each of the articles that were made, and including who the working group was that provided the initial drafts of the revisions, and then the summary of the changes, and then the track changes version and a clean version for you to read. I want to provide a little bit of historical context for why you haven't seen a bylaws update in a few years, and also just how the working group, how the bylaws committee works. So there is a bylaws committee that's comprised, per our own bylaws, of about 7 medical staff members. We also have an affiliated professional who serves on the committee, who previously led our CIDP group. We have representation from our medical staff services department, and then also we're guided by our our deputy city attorneys, who participated and give counsel on how to amend our bylaws. We're usually on a 2-year cycle. And as you are aware, we had a few of us have changed leadership roles too. So we have been on a few-year cycle for changes. There have been a number of regulatory changes, including the SB 8090 with the NP 103 privileges. There had been a number of medical disciplinary cases that involved both medical staff and affiliated professionals, where we needed to rely on our bylaws regarding the process. And we had found over the last 4 years that there was a very clear process, particularly or outlined as pertaining to affiliated professionals. And so there had been a number of recommended changes that council through the city attorney's office was looking at. There had also been some changes in terms of balancing medical disciplinary and code of conduct discipline related to EHR standards and privacy standards, and ensuring that was clearly spelled out in our rules and regulations in the hospital, and also maintained procedural rights for medical staff within the bylaws. So all of those things have been were being researched and drafted by our councils with the city attorney's office and by our bylaws committee. And so this particular document has a number of things that at a high level clean up some unclear procedural language for both affiliated professionals and for medical staff, in terms of who is entitled to due process, and if not entitled to due process, what is the process for affiliated professionals, and then additionally making sure that the language was inclusive throughout the document from all parts of the credentialing, appointment, privileging, and the the quality improvement, the focused practice and professional evaluation, process, the FPPE process, that was clearly applicable to all members of the medical staff and affiliated professionals. So we really tried to make the language as inclusive as possible throughout all of the articles. And those are the high level changes that were made. And then I'm happy I know there were some questions about particular areas, and I'm happy to go through some of those specific questions now and responses to them. But I also wanted to talk about process with all of you, because there are a number of substantial changes that we are recommending in this document. And we also want to ensure that you have sufficient time to review it while also following our own bylaws in terms of when and how amendments should be made. So my understanding is to be able to present to you at a meeting this month, this meeting. These are the summary of our recommended changes to give you an opportunity to review them, which I understand can happen asynchronously. And then our hope was that in May, at one of our MEC meetings, which are mid-May, that we can present these recommended changes along with any other suggestions that you might have in writing for in addition to what President Green shared a number of recommendations today, but we would share those also with MEC, and then it would go for a vote to the full medical staff in June before coming back to you and the full health commission for approval in July.
So this is not up for a vote today, this is just for discussion.
This is just for discussion.
Okay, so, well, you're right, there are a substantial number of changes and the additionality of affiliate medical staffs that I have. And I think it's important for us to really give adequate attention to these changes and to be sure that they are those that the commission would also find acceptable. And so I don't know about the timing, because I think one of the issues would be that I would like to see is that we get the different comments from the commissioners and be able to present those to you. But at the same time, I think it's important to have some sort of a dialogue about these comments and the ability to hear and talk out what were some of the points. So
Yeah.
if President Green had sent some, I haven't sent any yet. Already looked at all the little tabs I have here.
That's wonderful.
And I'm sure Commissioner Christian will be able to also review that, especially from her own perspective and as an attorney. That might be something which we could all collaborate and make sure that the changes that are occurring really respond to what we've all seen as sort of some lack of clarity in the bylaws, especially as it relates to the rights of appeal and so forth. But your timing wouldn't exactly work right for that, because
Because we lost it in May.
There's no meeting in May, right here.
Really, nay, correct. Are you concerned about getting the comments in before MEC considers? Is that what your concern is?
Well, I was hoping to be able to do that, because it doesn't do any good to have MEC look at this and say, oh, that's great. And then all of a sudden there's a group of comments that will perhaps make changes.
Well, Commissioner Chow, is it possible that you continue your review and then submit comments as part of that process? And then in the past, Dr. Mercer, we've set up a meeting between Commissioner Chow and someone in your position to have like a private meeting where he could share those, and then you can still get your discussion in, and that wouldn't be a meeting of the full group, so it would be appropriate for you to meet with her or staff.
Well, I'm not quite sure how we would get a meeting of the whole group if we're not having a meeting.
Oh, no, I'm saying it wouldn't be the whole group, Dr. Chow, it would just be you and Dr. Mercer and her staff, so that you could provide comments. President Green has already provided any comments.
Well, it wouldn't be only my comment, because I think everyone has some comments to go. And we might, and I think it's best that commissioners actually understand what the comments were from each of the commissioners.
Yeah.
Uh,
I was wondering about that, and I guess I was also just wondering around this forum versus either another meeting or and happy to defer it to a later, just in the, to a later meeting in June, and we can certainly move the vote for the medical staff. I'm also happy if we wanted to ask about some of the comments in the context of prior closed session business, because that seemed to be the greatest sticking point. I also was going to say I am happy to, even today, walk through some of what the changes, just so you have a flavor of what you're looking at in terms of the changes that we're recommending in the closed session, because it does pertain to prior actions that we have discussed.
And is your timeline based on regulatory need, or could you push the?
No, the MEC, I think the vote, my hope was that we would present the recommended bylaw amendments at the full med staff, the annual meeting, which is when we have a large representation of all of the active medical staff who need to vote. But our bylaws allow for electronic voting. So I could also present at a very high level, I was gonna, at that meeting, it would be a high level presentation anyway. It would be, we can make it more of a anticipatory presentation of the high level changes, and then let people know there will be an electronic vote.
Okay.
Yeah, I suspect that the high level changes and the areas of emphasis that you're gonna have are not going to change greatly. I think to some extent, right, the devil's in the details, which you want to be sure carry out the high changes and not have something unexpected come out. So it seemed to me that there are several things. One, I think we should take advantage of being able to walk through us at the level, because you've actually helped outline already where some of the changes were, and it was very nice to tell us who actually led some of the discussions in the articles, so that we had an overall view right now of where we are. I think it would be good to have each of our individual reviews submit to you questions. Those questions could get responded to, perhaps, and to which we could circulate to everybody to understand, because each of us will be looking at it from a sort of viewpoint. Then come back together at a meeting to then see if there's some common consensus over which areas we have concern about, or maybe none at all by the time we got the explanations, or changes that you might be proposing to respond to the explanations.
Okay, so I'd like to review that, because I'm a little good. So a little bit more discussion today, but then delay. So high level at the med staff meeting, but not a vote. And then in June, you all will come back and discuss more, and then take it back to the MEC for them to.
Right. I think by that time we might have a consensus about where, if there are some areas. And meanwhile, legal could also then say, okay, well, perhaps that's not as clear. Here's a change that we'd like to propose, or most of it, I think, would be understanding from you all, including legal, what some of the questions are that we have to raise in terms of the changes.
Sure. I am very appreciative of that process. And I do want to reassure you that the city attorney's office has been involved in every step. Now, Mr. Levy just left the city attorney's office and has taken a new position. We're very excited for him. But in another county, and Ann Pearson, the deputy city attorney, is her team is continuing to support us. But in addition, they have retained another firm, Bridget Hansen, who specializes in medical staff issues, and they have done a review of this, and I think there are enough, I want to make sure that our process in making these changes and codifying a process for our affiliate staff members is happening as expeditiously as possible, and correcting some of the procedural rights issues for the medical staff that were in the prior version. So I agree to the process that you're outlining, and I would love us to set a timeline for having this move forward with a vote for the full health commission, ideally, if not July, then for the August meeting.
Sure, well, and it's okay, I'm jumping in and doing this?
Yeah.
Okay.
Right,
So-
let's hear what you're.
Sure, so end of June is the meeting here, where they will give the comments, and then in July, you all would have the NBC meeting, so, I don't know what the NBC meeting timeline is. The commission meetings are the first and third Mondays of the month, so if it doesn't work in July, then it can be the first meeting in August.
I think it just depends on how much, if we wait to have the discussion and for the June meeting, I'm just thinking about timing for others in this meeting, but then depending on how substantive the changes are that you would like to see, I don't know that we could have it for July, but we could have it for August.
Sure.
Yeah.
I think we're completely flexible. It's
Yeah.
based on what you just said and the urgency. But would that work in terms of your concern with trying to get this through as quickly as possible?
If we can make the August work,
Yeah.
that's great. I'm also open to having if in the past, there's precedent for us meeting separately to go over specific technical details with the city attorneys, then I would welcome that.
Well, I guess Mr. Chow and Mr. Christian, who haven't reviewed in full, if you all come up with substantial things and we could have individual meeting, and you feel like that needs to be discussed before a public meeting, just so that you get questions answered, then you can be prepared for the June JCC meeting. But I think we can, based on what you're saying, I can make it work on our end.
Great.
For sure.
I think so as well. Also, I think it would be good to have the city attorney or the private attorneys that you hire present, so that, that can help speed up the process as well. If we send questions that are really kind of been directed toward legality of certain
Yes.
things, then,
That sounds great.
and I don't know whether there are any existing written guidance from the attorneys around certain points that you could share.
Yes, I have some, but it depends on.
It depends on the questions, right, but
Yes.
you would see the questions and perhaps
Yes.
something that you could
Yeah.
share that's already.
Absolutely.
So what we would do is, after we get this another high level review of what is sort of.
Yes.
So for your high level review for the medical staff.
Yes.
Questions submitted, it could work like our routine fashion where the submitted questions could either have a written answer back to everybody that we could then see, and then when we met in person, we could either follow through with those or or if they chose to answer verbally instead, to bring that to that other meeting that we're talking about.
Sure, and I can take notes of that verbal and summarize that for everyone.
Yeah.
So if we do that, and President Green, is this okay for you, just in terms of, because then ultimately the full commission will approve this?
Absolutely. I'm a little confused about what you said. So we worked with Hanson Bridges before, actually round one, and they handled most of our staff issues, and they're excellent. Do you think they will have input different than the city attorney on some of these things?
They've already provided input. So in the version that you're seeing here, their senior partner went through with me and provided the highest level changes. Because I will say, our bylaws committee is having discussions around, the procedural rights around for affiliated professionals, as some medical staffs do that, et cetera. And I think right now, they really helped us understand what the regulations say, what are existing. So in this version, you don't see, we are sticking with just allowing only to the regulations around affiliated professionals, but really clarified the process and also clarified, clarified all of the medical disciplinary wording. So it was very clear that for medical staff and for affiliated professionals, what standard everyone is being held to, that it's an equivalent standard.
So you feel for procedural rights and due process in particular, they basically got a second opinion.
Yes,
And then what's here is been adequately vetted.
that is my, yes. And I think that our committee and Bridget Hansen would like to look again next year because there are some best practices for like, for example, the California Hospital Association has model bylaws that actually, it might streamline everything. But right now, there are sufficient gaps in our existing bylaws that do not define a process where we really need to have that process very clearly defined.
Yeah, and I also think, well, first of all, I think having Nancy and Bridget as sort of a second opinion is very helpful because not just from the city attorney standpoint, that worked on these before and looked at witness about this before, and taking a council that has been working with the community in terms of both hospital and that I think is very helpful. So that's helpful. To be able to understand that there's been some vetting of this in that manner. Along with California Hospital Association, I encourage that we be sure that we look at CMA's model.
Yes, yeah.
And I haven't seen it for a while, what they've done with affiliate staff at all.
Right. So I think, and that's basically a question we have tabled till next year, just because right now there have been, many years building up of changes to be made and the process gap to be closed.
Okay, so did you have any questions or else I'd ask if then Dr. Mercer would help walk us through the substantial changes and maybe you can tell us why you changed from wills to shalls and shalls to wills.
That is a question I will defer to our attorneys. I think it was a personal preference on the part of different legal counsel.
Okay, so again, let's have you walk through what you feel are the substantial changes.
Okay. So would it be easiest to look at the track changes version?
Yeah.
And then I'll just go as expeditiously as possible. So in the preamble we added a few definitions and clarified, including for attending faculty. There have been some nomenclature changes for chief of service and chief of staff instead of service chief. There's clarity around the roles and responsibilities for the director of health. There's a definition of the clinical service. We had lacked a definition for the medical staff, and so we put a definition in there. We also added the definition of practitioner using the one from the CHA model bylaws, which is a inclusive term for both members of the medical staff and affiliated professionals. And then we also made a reference to staff, which includes all any employees or volunteers of the city or the staff or who are working as contractors who are not in the medical clinicians, who are not clinicians. And then we also made a note for designation of acting members of either executives or chief of staff, chief of service, etc. We tried to add, and we added a clarification of calendar days, not business days, just that again was there's not a rule that we could find that mandates one versus the other. We just needed to have clarity around whether it was calendar or business, and we chose calendar. And then I think there are other questions later on, we tried to extend the number of calendar days to be more inclusive for business days. In Article 1, there was a definition of equity that we added. In Article 2, we clarified the definition for temporary waiver and a permanent waiver, and this relates to the appointment of medical staff members who might not be ABMS, like who are medical graduates from a foreign university or residency program, but who met the criteria on initial appointment, but don't have a way to maintain ABMS. So it's requiring them to maintain equivalent certification and qualifications that needs to be validated through their chief of service. Now it's number 2. I think there are just some other nomenclature changes here. We added, this was a recent addition based on Bridget Hanson's direct recommendation in Article 2.8. We added some redundant language here, which appears elsewhere, I think in Article 6, around basic responsibilities of the medical staff to just include what you see is items F through I, which have to do with proactive behavior and quality improvement activities of medical staff members. So working cooperatively with other members of medical staff, reporting if there is a formal action taken to them, reporting if they have any disability. So these are things that are actually repeated elsewhere in the bylaws, but we wanted to have them be somewhere focused where if someone was doing a brief review, they would see it. And I think it came up in some of your questions, Commissioner, that there might be some other opportunities for us to make sure actually redundancy is helpful. In Article 3, there are just some minor changes with regard to definitions there. And Article 4, appointment and reappointment here. Most of the changes had to do with the, in Article 4's appointment and clarifying that procedural rights are not granted for if there's an adverse action to an applicant. So a new member, someone who's applying for membership to the medical staff, but we determined to not appoint them to the medical staff after the quality review process through Credentials Committee and MEC, that there is no procedural right granted to them because they were not a member of the medical staff. And that the same process holds for people requesting new privileges. So you might already be a member of the medical staff, but you're requesting privileges in a certain area. You are not entitled to procedural rights if you have not met the the minimum qualifications as determined by the Credentials Committee and MEC. And it just defines what the process is for notifying the chief of service if it is an existing member of the medical staff, but they don't get to a right to a hearing because they didn't get a new privilege. So our hope is that then the chief of service can work with them to make sure they meet the minimum qualifications and reapply.
That's a question.
Yes.
Sure.
So on that point, so that's very helpful outlining that. It seems like it's like the first one, not applicable to applicants. It's like if I, applied for a job and I wasn't hired, I don't
You don't get
have procedural rights.
Yeah.
Right, okay. And if I am on staff and I want new credentials, it's very fact-based,
Yes, either you met the training requirements for this and have demonstrated your case, load. And that it's pretty a standard review process through the Credentials Committee.
Is that more kind of quantitative look at things rather than a qualitative look?
It's both. I mean, you would, it would be, you might submit cases that you were supervised in, or through a training program, or you might have to have a certain score on a skills assessment. And if you didn't achieve that score, it really depends on what the privilege is. If you're, if you're applying for cesarean, like, for example, like, a clinician that hasn't performed cesarean deliveries, might be approved for privilege for vaginal deliveries, but not for cesarean deliveries if we felt they didn't have a certain number of them, or the person that was their evaluator submitted a subpar review.
It's helpful. Thank you.
That is 7, okay. And that's the 4.34, and it describes the process. So if there is an adverse, so 4.34, 4.35 describes just the process. It includes that process that I just described, and then the process by which someone is not appointed until it has come to the JCC, which is what we've been in closed session for. And then it also clarifies that, the governing body may also wish to defer action. And then it just defined what the process is. If on your review of the credentials report, you might actually want more information about a candidate or someone who is seeking new privileges. And so that would be then referred back to the MEC, and that gives us 60 days that we have to respond to your request for more information to move forward with an applicant. And what I want to call 4.75 corrective action. So make sure that it's skipped. So this is describing the process around affiliated professionals. Yeah, I just wanted to make sure. Yeah, so 4.7 is the section on affiliated professionals. So it describes, so this is back on page 8 of the track changes. It describes, defines affiliated professionals. 4.71A3 lists who are the groups of licensed professionals within the categories of affiliated professionals that we're considering. It just 4.72 describes their role, and we made some minor changes there, but clarified to the extent that state regulations require supervision of affiliated professionals beyond overall medical staff oversight, that additional relationship will occur as required by law. So that was from our lawyers to request those specific language there. And then in 4.75 describes what corrective action looks like for affiliated professionals. So it mentions that affiliated professionals are subject to the same oversight processes and quality improvement processes as defined in Article 6, which is corrective action for the medical staff. But that here it says any clinical privileges or standardized procedures exercised by the affiliated professional that is overseen by the medical staff may be addressed by the medical staff using the same or using similar concept as defined in Article 6, but that they are not entitled to the same procedural rights. They are not entitled to any of the procedural rights that are then further defined in Article 6 and 7.
You explain.
Yes.
Explain that more clearly.
Sure. So it is a little more clear once we get to Article 6 and 7, because it defines, Article 6 defines the FPPE process, so the initial FPPE, which is equivalent to proctoring. And then The secondary FPP, if there's a for cause reason that someone has an FPPE, everything for progressive discipline may be supervised by the chief of service to which that affiliated professional reports in the medical staff line up to the hearing process, so that they are not entitled to a hearing. So procedural rights means just that they're not entitled to a hearing that the medical staff are entitled to.
Might be really helpful for us to almost see one of those diagrams.
Yes.
How it flows and what the difference is.
Okay.
So on the one hand, affiliated staff often need supervision. I'm thinking about, midwives, for example. And that if there's an urgent need, it's a lot harder to have someone whose performance might actually undermine the quality of care, to have that person removed than it is to admit people. And once you need to go through that process, as we've seen, you see all over the place, it's a quite an involved process, during which time sometimes those individuals stay on the floor. And so it would be helpful to understand, since there's that later supervision required for, except the P103s or the ones that the NPs still practice independently, it would be very interested to see how that goes for independent or affiliated professionals in general, whether it's different for one type of, some.
Yeah, what, sure.
Procedurals, some are not.
What this is saying is that actually all of the medical staff duties, the clinical care, does report into the chief of that service. So in the case of midwives, if they have a collaborative practice agreement, yes, they have a supervisor and the midwife, but ultimately the chief of service is overseeing the corrective action and progressive discipline process. Okay. So we can provide a diagram for the follow-up. Okay. I'll move right along. The next section is clinical privilege.
Yes. I was just thinking, you were talking about the new independent nurse practitioner.
Yes, we don't have the fully independent. We do not have the 104s. We do not have NP 104s. NP 104 means the NP group could open a clinic and they're operating completely separate from physicians. In our frame, all nurse practitioners, including those with privileges, are still working with a supervising physician.
So how can that be clearer in here? Because it just says nurse practitioners. It doesn't say.
Well, I think that the language that we added in 4.72, which our lawyers provided, which says, to the extent that state regulations require supervision of affiliated professionals beyond overall medical staff oversight, the additional supervisory relationship will occur as required by law. So it's the point in the bylaws is the regulations may change. And so our bylaws need to just account for the fact that state regulations may change. We will follow them accordingly. And we're not going to specify the exact details in our bylaws because we need to refer to the state regulations, which may.
So you're feeling by not hiring the independent nurse practitioner, they don't come under this, of course.
Correct.
I mean, that.
Well, they cannot I see what you're saying. I mean, we don't have any structures.
We don't really define
Yes.
the nurse practitioner
Yes, true.
here and
Yes.
now. What you just said is that there are two types.
Yes.
of
Well,
nurse practitioners.
we're not we might hire someone who has NP 104 privileges elsewhere with the state, but we are not granting them NP 104 privileges at ZSFG. We're granting the privileges you approved earlier today were NP 103 privileges. So they follow the supervisory chain within our medical staff.
thinking, well, maybe it should be a definition of the nurse practitioners that are under this.
Well, I think it's just, there is on state regulations, NP 103 is a clearly defined, and that's what you approved today. And so I think that this 4.72 covers that, because maybe next year there will be an NP 105 that's created, and we haven't accounted for that yet.
Oh, right.
Yeah.
Okay.
Article 5. So this was mostly cleaning up. We added wherever appropriate that we are we are appointing people to the medical staff or to as an affiliated professional to practice clinical privileges or standardized procedures as defined by their scope of their license. And so we added throughout here references to standardized procedures to clarify that that's what people are practicing. And I think that's most of this inclusive language here. We cleaned up the emergency situations. So in the past, there were emergency privileges and disaster privileges. So in 5.4, emergency situations and privileges or affiliate status, this basically just allows for us like COVID. I think this section actually was updated initially right after COVID. And we said, oh, there are situations where we might need to hire or appoint people to the medical staff or to the affiliate staff who, for an emergency or a disaster. So we consolidated emergency and disaster, and that's the language that you're seeing in green, which describes that. And I'm moving on, and that's Article 5. Any other questions on Article 5?
I sent one.
Yeah.
I think.
Oh, you
I sent
sent one?
I'm doing it now, but I think on my list,
Yes,
I sent one back.
I believe I
Yeah, I
received which
sent,
one.
yeah. Section 5, I sent.
Okay, and I did write a response for that. But we need to bring that question to our council, but basically it would be up to the organization that was sponsoring them. They will need to have medical malpractice, so it's really up to the the city to just decide if we're going to incur that risk or if we're requesting that their sponsoring institution would cover their malpractice.
Yeah, there was just, it seemed like there was a section where where the stipulations were, the 5483, where at least like 4 possible organizations said someone who came in a disaster had to be affiliated. At least that's what it sounded like.
Okay.
And we had some prom event where you guys suddenly needed surgeons from Kaiser or
Yes.
the East Bay or something. They don't fit into one of these 4 rubrics. So
They don't. So they would have, but they basically, we would need to have one of the organizations, either the city or the university, basically sponsor them as a malpractice, for the malpractice, or they would need to have their own additional malpractice.
Well, this isn't, I think, the malpractice part. It said that particular section, and I
Okay.
wait for this to find it.
Yeah.
It seemed to limit the people who could volunteer
Okay.
as being affiliated with one of
Yep.
4 different entities. And they seemed like people who come from afar. So I was wondering if something happened in the city where the epicenter was here, and people from Walnut Creek could come and help us
Mhm.
because we had awful traumas.
Yeah.
You know, if they're not affiliated with one of these.
I will have the Bridget Hanson.
Page 15.
Yes.
Yeah.
Yep. I'll have the Bridget Hanson team. Oh, because of the DMAT, you're speaking about DMAT, and so the other organizations that are named there are part of the National Disaster Response System, which has its own medical malpractice coverage through the federal government. So I think for members of other medical staff of other private entities, they either have to have their own or be part of these that have vetted medical malpractice. But we can, in our follow-up, I'll have Bridget Hanson weigh in on that.
Because it sounds like those are the only people who accept. That's what,
Yes,
page
got it.
15.
Yeah.
your
Yes.
83 says, mainly people
Yeah.
claiming malpractice, but they're not part of one of these
Oh,
organizations.
so yeah, they're, right. This, because these go through, you can pre-register and your credentials are vetted. Because unfortunately, in a lot of disasters, people show up and claim that they are from somewhere and have credentials, or they have an active license, and then it turns out that they're not. And so these are organizations where if they show their card, there's a registry that we have access to and we can cross-check it. That's a great point.
Well,
Yeah.
I do think that, because a lot of people now have not actually joined any of these. I mean, at one time there was a big push.
Yes.
If everybody
Yeah.
did that, they would then have a card. So you might have people who are over at Sutter
Mhm.
and they're not operational and they need to come over
Yeah,
and make use of our operating rooms here that are operational.
Yeah.
And it would appear that there's not a real way to do it under here. I think that's what we're trying to say.
yes,
And whether we should have something, I mean, might be as simple as saying that, or on,
Yeah.
a California hospital medical staff or something like
Yeah.
that. But I think that's where the exclusion comes from, because certainly on the private practice side, or even in the group practice, not a lot of people are joining these organizations anymore.
yes.
And there hasn't been a lot of publicity on it, really. Yeah.
Yeah, okay, we'll
Just
follow up
consider-
with a more detail.
Because we don't want you to be in
Yes.
an area where all of a sudden, because that's much more likely
Right.
that,
I guess, I think what our council basically had said was that would be something that where we can have an emergency, we could have either an emergency amendment for specific people or a specific MOU where there's a legal agreement of a document. So that was their thought, but I appreciate your point is that when these disasters
yeah,
happen.
take somebody who's on a accredited hospital staff or something like
Yeah.
that. Because I understand the
Yes.
concern. You don't want just somebody walking in and,
Yeah.
not actually indicating,
Yeah.
and say, I'm a doctor, but maybe do this, of course. But
I will work with Bridget Hanson.
it just,
I can go.
yeah,
Mark, there was-
I mean, we don't know what facilities are available, and
Yeah.
the system here at one time was saying, just get to the nearest hospital if you are available,
Right,
knowing that manpower was going to be an issue
yes,
in trying to navigate even the streets possibly.
yeah,
And if the doctor lived next door in general, he could be helpful there. Or
Yes.
want to be helpful. But on the other hand, we have to vet that you're really the doctor you're saying you are.
right,
So I think that's what we're concerned about. which
Yes.
I would agree with that. I think it's important, especially for the
we can clarify,
county hospital to have this ability.
we can clarify. Thank you.
And Dr. Mercer, I'll write up the comments from today and send it to you. So that you
Perfect.
guys-
Thank you. I'm trying to mark this back. Okay, Article 6, monitoring and corrective action. This is these are part of the meat and potatoes of the changes for this bylaws update. So this really clarified what is the focused professional practice evaluation and to whom it applies. It applies to all medical staff and all affiliated professionals. And it is a core part of our quality assurance process and coaching and improvement. And then 6.12, letter F, we added a number of statements in there that although the initial and secondary FPPE are focused on education and improvement, any issues that are addressed during either type of FPPE, including but not limited to recurring issues and the failure to successfully complete a secondary FPPE, can be considered progressive steps in the medical staff's efforts to address performance, clinical quality, professionalism, and other issues. And it goes on just to clarify that, and that this information may also be shared with UCSF for UCSF employees or with city human resources for city employees as appropriate when a problem warrants a separate investigation or potential discipline. So it's really saying, you know, there are medical staff processes, we're overseeing clinical care, and that's what the FPPE process is for. It can, if you fail to improve during successive FPPEs that are for cause, that counts in progressive discipline and you could move into more serious corrective action or a recommendation to revoke privileges. And there might be an issue that involves both medical staff issues and HR issues. That then there are pieces of that need to be referred over to the respective HR, and we can share that. Section 6.2.1A goes to professional conduct and just describes that all members and affiliated professionals are expected to practice with professionalism. I think I mentioned throughout here, we added the term practitioner, which is inclusive of medical staff and affiliated professionals. And then we added at the top of this, what professionalism includes and how that's a core component of quality of care. In 6.2.2, this is describing the investigation process and the way in which we might investigate. We updated to reflect our new system for reporting. We don't have unusual occurrence system anymore. We have a safe system. And describes how the chief of service is involved. The next parts of this section involve basically progressive discipline, and it also clarifies that you don't.
You know, on the investigations and all, and I realize each department has its own rules, regulations, or is this all in sync with that?
They would be in sync with our bylaws. I think the key part for the investigation response for alleged inappropriate behavior is in section B, it describes the duties of the chief of service.
Mm-hmm.
And then it describes progressive discipline, verbal counseling, written counseling, action plans. And then it clarifies that progressive, although we generally try to follow progressive discipline steps, escalating, there are times you don't have to do verbal counseling only and then written. There might be an instance of behavior that warrants an immediate formation of an action plan, not just verbal counseling. So we added that in item 7. So then it describes the conditions under which medical executive committee approval is not required and procedural rights are not triggered. And so I'm very sorry, but actually I'm just getting sorry. Answer that. Identification. So this is just describing when MEC is not required. MEC approval is not required for actions that are taken by the chief of service within the progressive discipline rounds, and then when it needs to go to the MEC. Formal investigation describes when something is referred to the MEC, and then the MEC must be the body that votes on whether to pursue a corrective action investigation. And so it defines the timeline for the investigation and the formation of an investigatory committee. And then 6.42 describes procedural rights. Basically, we just clarified that either a medical staff member or an affiliated professional could be referred into an investigation, and what is reportable to the licensing body determine they're basically the requirements for when we need to file an 805 report. So even if we are suspending someone's practice for over 14 days, we need to report to their appropriate licensing body, whether it's nursing, dental, physician. Okay. And that's also clarified in 6.55. And that's Article 6. Article 7 is hearings and appellate reviews. And so this is describing the details of the procedural rights and the appeals process for medical staff members. So this does not apply to affiliated professionals. It describes the grounds for hearing. There is a section in here that in a prior version, so it actually in the current bylaws, it's in 6.2.4, but in the various years of revisions, it got moved into 7.2.2. And this was a clause regarding termination from the medical staff. There had been a clause previously that referred to actions taken by the Director of Health. And then here it says that the Director of Health may limit access to DPH systems and facilities in his or her duties. So it could limit a member's access to DPH facilities without invoking procedural rights, and that the member would not be entitled to procedural rights. And so after review with our legal counsel, that was determined to actually be not in keeping with the procedural rights that are granted under California regulations, and that we needed to, so we removed that clause because we feel there are certain ways that you can remove people's access to facility. Within our rules and regulations, we have clear processes by which EHR access and access to our campus can be limited. And that is a separate process from actions taken against medical staff membership and privileges. And so we just have to keep them in different buckets and have the process that is described in under state law. So that's been removed. The next part we described in 7.2.3, this is a very significant update, actions taken against affiliated professionals. So this describes, again, that affiliated professionals who are subject to corrective action are not granted full procedural rights, but it describes what the process is for review. And so this section describes that the chief of staff may appoint an investigatory committee to review the incidents and related issues around corrective action, and to make a recommendation to the chief of staff and MEC, and then what actions the committee can make a recommendation regarding the clinical privileges or affiliate status for the affiliated professionals. And that then the MEC is authorized to make a recommendation on behalf of the medical staff for the revocation of either clinical privileges or affiliate status of affiliated professional. And then it describes that notice needing to be given to the affiliated professional, and the process for the affiliated professional to issue a statement and issue a statement of rebuttal. And then it describes the timeline by which the chief of staff will then inform the governing body of the recommendation regarding restriction or suspension. And again, it allows a written rebuttal to be submitted to the governing body. And then the subsequent decision of the governing body is final. So we just really tried to clarify the process there. Questions? Then the next section, request for hearing, and the subsequent sections regarding hearings. We added a number of details around, there's some minor details around the request for the hearing and the timeline by which the petitioner has to follow to request hearing both to the MEC and then to the governing body. And then the hearing procedure. Then the next section, 7.36, describes the Judicial Review Committee. It describes their roles and authorities. It describes how they work with the hearing officer and kind of their prerogative to set the rules of how a hearing will proceed with the advice of the hearing officer. And then it describes the hearing procedure and hearing logistics. And so these details that are kind of in blue, track changes in 7.4. So the hearing officer, the chairperson of the Judicial Review Committee, the hearing logistics, et cetera. These are all based on our legal counsel's recommendation, based on our experiences with the hearing process and where we had lacked clarity before in the bylaws. So a number of procedural steps and guidelines, including discovery, et cetera, have been added. Around the process have been added, and then there's a whole section on discovery, 7.47, that has also been added. So I will let you peruse that at another time. And then there's some clarification around rules of evidence, rights of parties, and then voting, including that there's a simple majority. And thank you, Commissioner President Green, for noting that there was a comment regarding the tie. So we will clarify that. It clarifies what to do in the case of a tie if there's an even number on the Judicial Review Committee. And then the rest are minor changes of inclusive language. Oh, okay, that's Article 7. That's pretty much the end of the significant changes, and I can do a very quick review of Articles 8 through 17, which are minor and more logistical changes. So Article 8 talks about the structure of the medical staff, describes the roles and responsibilities of the officers of the medical staff, including the chief of staff, the chief of staff past. There's a little bit more clarity on process for selection of a chief of service, which again, we had in the last few years, we had a number of new chiefs of service that have been presented to your body. And that allowed us to clarify just the timing between the two organizations and before, make sure that the approval goes to the governing body before it's announced. In Article 9, that's Article 9, which is chief of service. In Article 10, this describes medical staff leadership and affiliated professional leadership, and just describes the roles and responsibilities and how the reporting is structured between the hospital and the university. Article 11 describes the committees of the medical staff. There are a number of committees that are required by state regulation, and so we just made sure that any updates that had been made in those committees were reflected in these changes. And some by joint commission requirements as well. And then we updated in section 11 procedural process for voting and attendance and maintaining membership. Actually, I'm going to go to MEC. In MEC, there had been, so that's 11.3 describes the MEC, and this section, we wanted to make sure that we were inclusive of the new leaders. A number of positions that were previously medical directors have a clear reporting relationship to the CMO, and so we are including the associate CMOs there. But we clarified who has voting rights based on state regulations and bylaws. And then the other things are just based on what committees wanted to have changed to make sure that they were in compliance with joint commission requirements, et cetera. So I'll let you peruse those, but there's nothing to point out there. Article 12 just describes the meetings of the medical staff, and we moved most things to a simple majority and then defined quorum for active members of the medical staff. Article 13, which is confidentiality of information and immunity and releases. We updated the language here and made sure that it was inclusive, again, of affiliated professionals being subject to the same expectations for confidentiality. Article 14, disputes, conflicts and dispute resolution, and this really describes the process for resolving disputes between the medical staff and the governing body. We added and clarified the roles of the chief executive officer and the vice dean in helping to mediate conflict should those occur. Article 15, there were some small changes, just updating the name of the Joint Commission, and just some minor changes there. That was Article 15. Article 16 is adoption and amendment, and so that's what we're going through that process right now. So we just updated some minor language there. Article 17, this was regarding miscellaneous provisions. And so the main area where we added was in 17.2, sharing of information for disciplinary and other investigatory purposes. Our council had recommended kind of specific details about our safe reporting process and our being subject to that we could have review by risk management and by the medical staff or by the privacy office or by either DPH or human or UCSF HR, and that we will follow investigations can occur concurrent. And then 17.4 was describing notice to the medical staff services department and the chief of service regarding action against privileges at another institution. And so this just describes how we should share information if we receive information about actions at another institution.
Well,
I will look forward to your more detailed review. Thank you for bearing with me in that summary.
That will make it so much easier.
Yeah,
Thank you so
yeah.
much.
Thank you. Yes,
Should the comments mean anything?
No, they just mean different people were in the document at different times, and we had to both separate the document and then put it back together. So,
Well, this was a tremendous amount of work and very impressive. And looking at all the people involved, because you've got these various individuals that were involved on every step of the way. And this is exhaustive. I mean, how many hours? What is this about? 3,000 hours worth of time among all of you?
I'm sure Dr. Ortiz and Dr. Winston can describe, but yes, there are some very committed chiefs of service that were involved in this, and a number of other professionals in the organization that contributed substantially.
You know, I was just working on really long. It's
Yes.
yes, thank you for walking us through. And now you see why we can't really do it today.
Oh, yes. I wasn't anticipating it to be final split today. Thank you.
It was a miscommunication between the
Yes.
staff around putting on the action list.
Yes.
That's fine, thanks.
Yes.
And I think we follow sort of the process we outlined earlier. We'll be able to get you information. You'll
Yes.
be able to really, probably even help respond already
Yes.
with, a clarity to it, or maybe make changes that, maybe, make some sense.
Yes, absolutely. Great.
Thank you so much.
Okay, thank you.
Like I would applaud you. Item 8 is other business. Business, we have a member of the public here. Other business, and there's also general public comment, but I'm just offering to you. It's okay to move on. Actually, there's going to be public comments. And then now general public comment. And we do have somebody. So you've got 3 minutes. And I have alerted the person to make a comment that we don't do back and forth, so you don't hear questions asked. Thank you. No. And the microphone is that square thing in front of you, so you can just talk in your regular voice. It should pick you up. Yes.
Okay,
Please begin.
yes. My public comment is, I am concerned about the public service layoffs. According to some of the flyers that are posted within the hospital, there's an emergency rally to protect public services, no cuts, no layoffs. They're going to be on the front of the steps in San Francisco City Hall on Wednesday, May 14th at 12 p.m. I guess some of the staff are concerned about the public or about the layoffs and about the ability for staff members to get hired. There's also been a concern about the quality of care at Zuckerberg San Francisco General, not only in terms of the wait times. For example, when you go to the emergency department, there's been times where it's taken over 9 hours to be seen, be evaluated. And oftentimes there, from what I understand, is that there are folks who leave the hospital because they are so annoyed of having to wait for such a long time before even being evaluated by a primary care doctor or a healthcare practitioner. And that does affect their, KPIs and their funding. And so it's important to really focus on improving some of these. In terms of their patient experience, there's no place for people to meet with the Office of Patient Experience one-on-one. There's no office that is ensuring the patient's privacy. For example, I was told to meet in front of a portrait where if you go in the middle of the hallway, there's nowhere quiet. So people are listening to your conversation. And so I advise them to please have an area where patients and Office of Patient Experience staff can meet privately. And if we could fix the phone line for the Office of Patient Experience, it should not take over a day or more for staff to get a hold of somebody. It should be right away, expected. Okay.
Yeah.
And then lastly, if the Office of Patient Experience staff could work at nighttime, because we know that these are where short staffing often occurs, that would be great. And I've mentioned these, and I really hope that you got the hospital addresses it. Also, if we can get more funding from Mark Zuckerberg or somebody, that'd be cool.
Thank you. Thank you very much. That ends public comment. And item 10 is a consideration for closed session.
Move to go into closed session.
Second.
All in favor, please say aye.
Aye.
Thank you. Angelica, would you mind calling Jessica and close the room behind?
We'll give about 30 seconds.
In open session, commissioners, you approve the credentials report and attendance report in closed session, please Is there a motion to disclose or not disclose discussions held in closed session?
I move that we not disclose discussions held in closed session.
Second.
All in favor, say
Aye.
Thank you, and this is a motion to adjourn.
So moved.
Second.
aye. All in favor, please say aye.
Aye.
Thank you. Thanks, everybody.
Thank you.